Hello, good morning, good evening, depending on where you are and what time of the day this is for you. Welcome to the second episode of the Touchpoint, which is a podcast by PMNCH that explores key issues related to women's, children's, and adolescent health. And today we're jointly conducting this conversation with the Race in Health podcast, hosted by the Lancet Commission on Racism in Child Health, which explores the nexus between health and racial justice. So as some of you might know, today is the International Day for the Elimination of Racial Discrimination. 2025 is relatively important. It marks the 60th anniversary since the signing of the Convention on the Elimination of All Forms of Racial Discrimination in 1965, and yet racism persists and affects the health and lives of many everywhere. So today we wanted to have a discussion about racism. So what is racism? How does it manifest in health systems? And then what does that mean effectively for the health of all people, but in particular for women, children, and adolescents? We'll also look into some of the solutions to addressing these issues and to try to have a better understanding of what we can do as individuals to help mitigate the problem. My name is Kedi Touré. I head communications at the Partnership for Maternal, Newborn, and Child Health. And I have the pleasure, I'm really honored to be joined by Delan Devikumar, who many of you know is a professor of child health in the Global Health Institute at UCL, which is University College London. He's also the chair of the Lancet Commission on Racism in Child Health, and more importantly, a brilliant mind and a tireless advocate on these issues. So welcome, Delan.
Hi, thank you very much for having me on your podcast today.
Of course. So I wanted to start maybe by setting the context for everyone and trying to understand, what is racism? How does it manifest in health systems? And what does it mean for health equity?
Thank you. So I guess most people would have some concept of what racism is. And I think most people think about it at an individual level: racist acts of abuse, racist acts of violence. But really, it goes through multiple levels of society, from the structural forms of racism that exist in how societies are set up to marginalize, persecute certain groups of people, all the way down through the systems, through the communities, to that individual and the individual interpersonal acts of racism we might think of. Racism also goes beyond that, and it can be internalized. So people internalize racism into their system. It can be vicarious, so the racism that I don't actually experience myself, but maybe see through other members of my family, I can still feel the effects of that racism. So racism exists through multiple ways through societies. Your question was about the health system, though, and within the health system, racism can exist in multiple ways, not all of which are deliberate, and I think that's important to say. So sometimes it's just the way that system is structured. So if we think about issues of access, for example, where a hospital might be placed physically might be further away from a certain minoritized community, so they can't get to that hospital. There might be issues of transport, the cost of transport, the accessibility in terms of the hours that that hospital or clinic is open. So there are those kinds of barriers that exist, which are structurally racist. Of course, there are, overt acts of racism by health professionals towards patients and public. The other way around as well, health workers facing racism within the system. There may be barriers such as language barriers for, say, migrant populations moving to a country who don't understand. And, I say this as I'm a clinician myself. I'm a professor of health, and I still struggle to understand the health system in my own country. I still struggle to understand how I go from A to B to C to get the treatment I need. So it's not that this is easy, even for someone like myself. So there are lots and lots of issues. It goes into the quality of the care, the physical aspects, as well as those overt aspects within the health system. And I think racism covers all of these.
Thank you for that. It's very interesting to note the sort of different levels at which we experience racism, from structural to the individual. It's also, I think, a refreshing take to focus on the idea that even the sort of recipients of racism, or the people who experience racism, can internalize it to a certain extent and sort of perpetuate that from themselves. And I think it points to the complexity of the problem, and sometimes the non as you said, the non deliberate nature of the problem in certain instances. So if it is a problem that sort of covers all of those spaces, what does it practically mean for women, children, and adolescents? How do we see this spanned across sexual, reproductive, maternal, newborn,
Yeah,
child, and
yeah.
adolescent health? Yeah.
Yeah, so racism is one of the big determinants of health, and I think we need to think about it alongside the other big determinants of health, and that's something that often isn't done.
Mm,
And I would urge any clinicians to ask questions about racism when they're
mm,
doing their consultations. And this isn't something that I did. When
mhm,
I worked worked in pediatrics as a clinician, I didn't do that. So I realize it's a push I'm asking others to do.
mhm,
How does racism affect health? Well, um, I would start by saying this happens in every society, in every country around the world. It
mhm,
might differ by country. The group who is affected might differ in each place, and we don't
mhm,
always have the data. So
mhm,
in some countries like the UK, where I am, we have data that splits up by racial or ethnic group, but we don't always have that. So sometimes that picture is a little opaque.
mhm,
But what we see is that there are numerous examples of how racism impacts health adversely, and that occurs across the developmental stages from preconception through pregnancy, newborns, infants, children, adolescents, and then later adults, and even the children of those children later as well. So this
mhm,
life course approach. Um, and we see, for example, differences in mortality data from the UK for
mhm,
Black women in pregnancy compared to white women, and also Black infants compared to white infants. In both cases, we see about a 3 times increased mortality for Black
mhm,
women and for Black infants. And this is in a society where we have a national health system. We have, in theory, free at the point of access. Uh, there's a study, and I'm just sort of picking examples here. There's a study from Panama that looks at indigenous health and finds that
mhm,
indigenous infants have a nearly 1.5 times or 1.4 times increased risk of dying from congenital heart disease. And these are things that shouldn't happen.
mhm,
There is no biological difference here going on between different ethnic groups, different racial groups. So mortality differences, well, mortality should be the same, but we see these differences between
mhm,
groups. We see qualitative evidence from the USA, from the UK, talking to women in maternity care who talk about experiencing lower quality, less timely, feeling rushed. And this compromises their participation and involvement, and it acts as a barrier. It
mhm,
affects their decision making. We see effects in children, in adolescents, particularly in mental health. I think that's where the evidence is strongest. A study looking at indigenous populations in Australia, you see differences in mental health
mhm,
problems amongst indigenous groups there. And then if we broaden this slightly, so if we think about migrant populations,
mhm,
trafficked people, that occurs more commonly amongst minoritized groups. Just some examples from Nigeria, from Uganda, increased examples of violence amongst those trafficked groups.
mhm,
And I want to go a little bit beyond, because I talk a lot about how this happens structurally in the political sense, but there are biological mechanisms. So we can look inside the body and we can see how racism activates these hormonal changes, these
mhm,
we call them epigenetic changes even within the body, that increases your stress levels. This idea
mhm,
of weathering, which described by Arlene Geronimus in the US. And this increased chronic stresses that people face throughout their lives increases their risk of non-communicable diseases. So what someone might experience as a child may actually present decades
mhm,
later in terms of chronic diseases. So it covers a whole spectrum, and I would argue it's an under considered determinant of health.
I fully agree. I recall the first time that I saw the maternal mortality differences in the US, which have a tendency to be slightly higher than those in the UK. I was completely shocked. And we look at a certain number of countries and sort of average out the mortality rates and don't realize that within certain subgroups, you are actually looking at extremely high rates there. So I wanted to pick up on one of the points I think that you made that was quite interesting for me. I've done a little bit of research on this question and have found data, but that sort of emerges from a certain number of countries, right? We have quite strong data from the UK, from the US, some examples from Mexico, Brazil, you mentioned Panama, we've seen South Africa, Australia, New Zealand. But because sort of I wasn't able to find a systematic evidence across a range of countries, it sort of leads to the conclusion that racism isn't a global issue. And I heard you say that it definitely is a global issue. So what are some of the challenges that we have around collecting data and using the data around this so that it can be perceived as this priority determinant of health?
Yeah, absolutely. And I really think that this is a global issue. But the data problems that you talk about is one of the major barriers to thinking of it in that way. There was a systematic review, and this is now about 10 years old, by Yin Paradies and colleagues who looked at racism and health. And looking at all the literature at that time, they found that 81% of the literature came from the USA. So vast majority of the literature emanates from one country. And then if you add in the UK, Canada, Australia, that's another 10%. The rest of the world was less than 10%. And at the time, no studies from low middle income countries. I mean, that has moved on. A recent systematic review by Naomi Priest and colleagues looking at racism and child health did see an expansion of literature. There are some studies from low middle income countries, but that proportion is still about the same. It's still about 80% from the USA. So it's vastly skewed towards a certain consideration, a certain context, looking at health outcomes amongst Black people in particular, Latin Americans coming to the US as well. And that's not to say that, there is a big problem there. It's just that is one aspect of what this is around the world. And this happens in the UK. It happens in every country I've certainly worked in and visited. But it happens in a slightly different way. And that's important to say. So different groups can be higher or lower in that hierarchy. Different groups can face worse health outcomes compared to other groups. So it's not always the same. And that goes back to each country's particular context, history, what's happened, the way those countries are formed in many cases, going back to the colonial histories of many countries around the world. So I do, certainly agree that data is a problem. Sometimes there are issues in how these studies are even considered. So a study that might be about racism doesn't actually use those words and doesn't use that concept of racism. So it doesn't always get picked up in the same way. Certain countries don't think about the issues that they face. And, we see wars and conflicts, civil wars around the world based on these ethnic, racial, religious differences who don't consider these issues in a racism framing. But a lot of this, it is the same thing. We're talking about differences between one group and another group and marginalization, persecution of that other group. So it's a broader concept of racism, which I would argue happens everywhere.
Okay. And I think that's an important point to make, and I think a call for data gathering on this issue. So if we accept that this is a global issue, we accept its sort of embedded nature in various structures and systems and in individual perceptions. What do we do? I heard you mention interrogation a little bit early on, but what are some of the solutions? How do we reduce the prevalence of racism and its impact on health outcomes?
So I often very unhelpfully say we have to do everything. And I know that that isn't a good thing to say, but I guess I say that. So we, in some of our previous work, we mapped interventions, and we looked at interventions from that kind of individual level all the way through communities and spaces and systems to the structural level. And so we looked at all of these interventions, and we see that the bulk of interventions tend to be that individual level. And I'm sure many of your listeners would have joined training sessions, for example, diversity training sessions, so that type of thing. I know I have as well. And those types of interventions don't work very well. I mean, there's mixed evidence, but there are issues in how they're evaluated, certainly. So evaluations tend to be very short, but on the whole, they're not great. The more structural interventions at the other end of the scale tend to work better. So these are changes to laws, change to policies, changes to a constitution. Of course, these are very difficult to do. We think of change to apartheid laws in South Africa, these massive changes to society. So across that range, there are the ones that are more common and the ones that are rarer. And what we want to do is think about those bigger interventions at the more structural level. But I would also say we can't ignore the child who comes to an emergency department who's been racially attacked. And, we have to deal with those issues, dealing with the problems that we face. And so we have to think about the causes and how we stop racism, but also deal with some of those consequences. Some of our recent work has been kind of mapping these interventions for children, 80 odd interventions, and then trying to understand some of these mechanisms by which they work. And there are lots of interventions for child health, but I think importantly, they have to work in an anti-racist context. There has to be laws and policies that focus on racism. We have to think about how are those minoritized communities affected? How can we target interventions at those communities? Because it's wonderful to come up with a new vaccine, and being a child health person, I want new vaccines, but one of the major problems is just getting it to those people. It's getting it to the groups who don't normally get it. It's the recent migrants who've come to a country who move and they've lost their immunization schedule, and how do we get those vaccines that we have already to those groups of people who might be missed by the health system. So I think that kind of equity argument is an important thing I want to stress.
So that's excellent. I think I think you point to the need to take a multi-pronged approach that addresses everything, but I am hearing the need to focus on sort of creating the enabling environment, and sometimes doing the work that's the hardest is the thing that's going to make the difference. So duly noted. I do have a question on why we haven't seen sort of faster progress, right? I would argue that in the past 4 years, we have seen increased research, and I think you alluded to it earlier on in the conversation on this question. The sort of untimely demise of George Floyd did stimulate quite some movement on this. We saw the Lancet O'Neill Commission on racism and health. We have the Lancet Commission that you're chairing right now. We've seen increases in research. So why is that not translating into these shifts in policies and laws that we're talking about, or their implementation? What are the bottlenecks there?
Yeah, and I think you in PMNCH and WHO would probably know this better than me, but evidence is only one part of this picture. How do we take, I agree, there's been an expansion of research on racism. It's still, I would argue, very under-researched as a topic, and there are big gaps in this as well. But how do we take what we have into the policy field? And that could be at a local level, or it could be a national or international level. And there we get into local politics and think about how do we transmit these messages? And there are strong opposing forces, and some of these opposing forces are increasing. We're living in an increasingly polarized, divided world where these kinds of issues are at best dismissed, sometimes actively opposed. that people don't want to address these issues and people try to stop addressing these issues. So
Mm.
getting from that research evidence base, building that evidence base, trying to understand that evidence base, to moving to the kinds of interventions. And I think people like me, I think we're also at fault in that I don't think we do these interventions well enough. I think we need to think about, are we looking at the right timescale? Sometimes an intervention that happens now, you won't see an effect for 5 years, 10 years, 20 years later. And the other argument I would say is that we don't think of interventions in a system. Racism is a complex system. And there are these linkages between that individual level, between the health system, between the structural aspects. And we need to connect those things together. And we need to have an intervention that goes to multiple points in the system that work in cohesion. And then we need to sell it to people who make decisions. They need to understand what this issue is and then act on it. But a lot of it comes down to the politics of the country and how that country is structured and whether this is receptive as well. And that's, I would argue, becoming increasingly difficult.
We've been reflecting on this and discussed a couple of weeks ago the need to sort of strengthen the advocacy work that we do, particularly grassroots advocacy, to mobilize political change. Because, like you say, we are in an environment that's increasingly regressive and restrictive, particularly around sort of the anti-rights movement. And so the need to really anchor our advocacy in realities of the people that we're trying to service and make sure that there is reach there is important, I think. So that encourages me in the work that I do. And sort of one of the commitments that I'd like to make is that I will strive to take an anti-racist approach to the work that we do, because like you say, we don't interrogate this particular aspect of in our day-to-day work. So that being said, what in terms of parting words, what would you recommend to all of our listeners? What is one thing that they could possibly do that could help contribute to moving this issue forward?
Yeah, so beyond my statement of you need to do everything, I think I think it's taking racial equity, and I work in child health. This goes to broader than maternal child, adolescent health. It goes beyond that as well. But thinking about racial equity in health in everything that they do, and that could be a clinical interaction if that's what you do. It could be a policy level if you work in policy. It could be in research, in all aspects of this health system. Think about this racial equity in health, because is the thing that you're doing reaching that marginalized, minoritized population? Can you do it in a way that encompasses the whole population? And there are different approaches for each of those groups, and we could get into the nuances in that. But if you even ask that question as a first step, I think you're going towards improving health equity and improving child health, maternal health, and health more broadly.
Thank you so much for that. So to everyone listening, you've heard it here. We know that racism and racial discrimination is a major issue. We know that it plays out in health systems, in underpinning structures, as well as at the individual level. We know the impact that it has on women, on children and adolescents globally, and we know what to do to address it. So let's see what we can all do to try to resolve or at least mitigate the impacts of racism on health outcomes. So as you walk away from this podcast, please think to yourself, what is the one thing that you did today? How did you reflect on where racism fits into your work? Please follow us again on Touchpoint for more episodes. Also, please do go on raceandhealth.org to follow the different podcasts and the different updates from the Lancet Commission. And with that, I want to thank Dylan for indulging us today for this great conversation. Thank you so much.
Thank you for having me on this.